welding. It is muted. Turn it on. Is yours muted?
Oh, mine's not on.
Click the green speaker button. Hi everyone, is that better? Can you hear us? Yeah.
There's a little
Nope. No. Things. Can someone just ask a question whether you can hear us now? We haven't started yet. Thanks, Farhad. Yes, thanks, Christy. Okay, excellent. Thanks for your patience. We just had a little technical difficulty when we were starting here. So welcome to this of our second webinars presented by the College of GPs Victoria Faculty Drug and Alcohol Committee. My name is Paul Grinzi. I'm one of, I'll be facilitating today, and I'll introduce my panel now. So we'll look at get the next slide up. Which is a lot of practicing for us in terms of things. Okay, excellent. So to your left, Dr. Rob Weiss. We've got in the middle of our panel, Dr. Michael Alfgang, and sitting next to me, Dr. Cameron Loy, all very experienced GPs. And the important part of this is a presentation by GPs for yourselves, and a lot of you out there are GPs. So welcome to this. Now, before we get started, I just want to go through the invite. There's just your screen that you're probably seeing. So generally, there's a few different things we have to look at here. So I'll go have a quick overview of the GoToWebinar panel, especially for those that are joining webinar for the first time. Now, on this slide, you can see at the top you have the web address for technical support. If you're experiencing any technical difficulties, please to put a question up. We might be able to solve it like we did with the volume initially, but otherwise, please email them. We can't actually solve any IT issues on the run while we're running the webinar. Hopefully, we won't have any issues at all. Now, next to that, you can see a red arrow. Use this arrow to hide or unhide the panel. Basically, whenever you want to type a question, you'll need to obviously unhide the panel. You can also raise your hand as a function, but we strongly recommend attendees type a question rather than this, because often there are a lot of hands and we can't tell whether they need to ask a question or not. So basically, everyone's muted. You can't actually talk to us, but please use the question box to ask the questions. Now, the audio box gives you the options to listen via a telephone line or through the speakers. So if your speakers are cutting in and out, it's often a bandwidth or internet issue. You can actually use the phone line to call in. And if you're using speakers, we recommend you use some headphones as well. And lastly, the questions basically the interactive part of the workshop here, so the webinar. So the question part is where you can ask questions. If there are questions just to us, we'll look at those directly, but we can also share the questions, and we will be doing so throughout the duration of this webinar, and we really rely on some of the interactivity from you guys. So let's get started. Just to make sure the technology is working, we're going to start off with a poll, and we've got a new slide coming up now for you. So you should be able to, once we've launched that, basically for you to just select 1, 2, 3, 4, or 5 against the actual category that you feel like you're in. Oh, well, not feel like you're in, you actually are in. So what sort of participant are you? Just give us an idea of who you are and get familiar with the system we're using tonight.
60% voted. Here we go.
So we're getting up to about 2/3 of you have put a response in. Just wait a few more seconds until we get a few more coming in.
Can't see. 52.
I'll give you 5 more seconds. You can't be fence sitting on this one. This is a simple question. Excellent. Okay, we might close that poll and just look at the responses here. So if I read things out, we've got, according to our poll, we haven't got any medical students with us at the moment, although there's about half the attendees, still be more people attending, so they may come along board. We've got a small percentage of GP registrars, so welcome to you. Double the registrar numbers in GP new fellows, so welcome to you and congratulate you on your fellowship. And then the majority, just under half of the participants overall are GPs with over 3 years experience. And then we've got about a quarter of participants describing themselves as other. So we've got a registered nurse and an international medical graduate are the 2 people so far who've, in the question box, put down what sort of practitioner they are. If you've missed the poll, then you can put it down. So hi, Robbie, the RN. And we've got a number of people responding now, so I won't go through all those, but welcome to all those that aren't GPs. This is a GP focused thing, but it's obviously going to be important for other parts of our health professional colleagues who are working within this sphere as well. So let's move on to our next question and we'll open the poll for this one. So just hold on until we get that going. And the same again, just type 1, 2, 3 or 4 in this case. Whereabouts you're mainly based for your clinical practice, and those of you who are working in different areas, just pick the one that's that best relates to where you are. Again, we've got about 2/3 voting so far, so let's say it's neck and neck, urban and rural. 3/4 of you put a vote in so far. So for those that are listening and haven't done anything yet, if you can either press 1, 2, 3 or 4. And I think if you're on a touch device, you can just touch the response from there. So excellent. All right, we'll close that. And I'll just read out the responses. We've got 48% are urban based, 40% rural, 10% in the regional centre, and 3% remote. So welcome to everyone. We've obviously got a range of people from all over Australia and possibly internationally as well, but this is very much an Australian-based webinar. So welcome. We'll go through to the next and the last of these sort of series at this stage. Open up the next one. So we're looking at how did you hear about this webinar? Interesting to hear how you actually heard about it. Find it how we can improve our methods of communication. All right, approaching 2/3 of the audience again. I'll give you 5 more seconds to choose if you can remember how you found out about this. And we may close it now. Thank you. All right, so just going through that, the majority have, 4 out of 5 participants have heard it through the Victoria Faculty newsletter, which comes out to all Victoria Faculty RSCP members. I understand that a lot of people are also from outside of Victoria here, so some of you may have found out through a Facebook page, such as the GPs Down Under group, which is on Facebook for GPs. 5% word of mouth, and we've had about 12% emailed through other organisations. Well, Twitter's not working, obviously, for us. No one got it through Twitter. Or we may have heard it from Twitter elsewhere, but the main reasons weren't Twitter there. All right, thank you for giving that. It gives us an idea of who we're speaking to. We're going to start off. This today is really much a webinar focusing on a case, and then we'll discuss the issues around the case. It's certainly not a dry PowerPoint by any means, and that's why I've got 3 esteemed colleagues next to me who are going to help with the discussion. And we're relying on your questions as well. So we're going to, I'll read the case out. If you haven't already downloaded it, please do so. There's also on the panel of our webinar a thing called handouts, and you can click on the handout icon, Study Case DNA Webinar, and that way you can download it directly if you haven't had an opportunity already. In the meantime, I'm going to read out the case of Mel. So Mel's a 37-year-old female who lives with her partner in safe and stable housing. Mel's employed full-time in youth work and loves her job. Now, she suffers from anxiety. I always have, she says, and gives a history of being prescribed antidepressants for some brief periods as a teenager and diazepam, which helped initially. Now she gets panic attacks regularly, and the only thing that helps her is alprazolam. She developed lower back pain in her early 20s when she took over-the-counter codeine products. Now, over time, she eventually started seeing doctors being prescribed controlled-release oxycodone most of the time for her back pain. She was doctor shopping for both benzos and opioids for about a year or so, but because she had a stable income, she decided to buy it from friends to avoid the hassles of doctor shopping and to avoid entanglement with the authorities, which could affect her job. Now, she describes many years of fluctuating moods and has been told she has a mood disorder diagnosed by a psychiatrist. There was a past history of polysubstance use when she was in her 20s, which involved cannabis, heroin and alcohol, and this morphed into opioids and benzodiazepines almost exclusively. Now, she denies any amphetamine or methamphetamine or ice use, and her bloodborne virus testing has remained negative. Mel feels she has control over her codeine and oxycodone. After all, it's not like when she used heroin in her 20s, and she really takes it for her anxiety. Now, she quotes, "Anxiety is my major issue, and it's just getting too hard to shop around for the treatment I need." Now, she attends today because her pharmacist refused her any codeine until I saw a GP, so here I am. So that's the case. We're going to talk about that case and go through that. So if you haven't already downloaded it, or if you're happy with my verbal reading out of the case, we'll now proceed. And I'd like you to initially here just type in, not the chat box, but the question box. What else would you consider in your assessment of Mel, beyond what we've already told you? What else would be important for us to, or for you to find out about Mel's history here? So please use the chat box or the question box, and we'll share those responses as they come through. So how do you share? Can you share each of those as they come through? Yep. You can't do a shift. So I'll just read some of those responses. We're trying to get them up on the screen for you. So overdose, suicide, childhood and upbringing and relationship. We've also got responses in terms of a heads assessment, further family history. Now, someone said a complete biopsychosocial profile would be helpful. Yep, nice broad statement there, but certainly that's very important. Smoking, alcohol and other substances. We've given you a bit of the history there, but certainly we can explore that further. Has she tried any other treatment, counselling? That's a really important thing to look at. How long has she been using oxycodone? Is it helping with her pain? How does she feel about her medication use? And is there anything she'd like to change? Past traumatic history, yellow flag, some of the mentioned heads assessment as well. Has she ever been to a pain management clinic? So excellent questions there. So hopefully all those coming up. Can someone just say yes or no, whether you can see the responses that are in the question box so far? Yes, excellent. Thank you very much. At least we know our technology is working. We had trouble with that with our first webinar. Okay, so a number of things there. Excellent. I suppose I'm going to ask the panel now. They've been quietly listening and watching. From your point of view, what do you think are things at this stage that you would be asking someone like Mel? First appointment, she's just landed from the pharmacist. You've got this history so far, or you already may know this history, but what other things are really important in this initial phase, this first consultation when you've got limited time? Michael, you may start. You're in the middle. Firing
Okay,
line.
so I think part of the first thing that we need to be assessing with Mel is her motivation for change. And we need to try and establish some baselines and some rules. So we want to try and work out what her supports are and exactly what people have been saying about her history, what other factors may be involved. Has she been charged for something? What other treatments has she had in the past, as we try and map out where we're starting with her and where we need to move forward. And I guess that's what a lot of the first assessment is about, as well as actually setting the rules of a treatment paradigm. Okay, you're now in this situation. This is acceptable. This is not acceptable, and these are the options that we can give you.
Okay. So, Michael, part of that was alluding to what's acceptable or not, so setting some boundaries very early.
Yep.
Rob, what boundaries do you generally talk about with your patients in this sort of setting?
Well, before we go on to boundaries, if I may,
Yeah, please, yeah.
I would sort of want to know the amount of substance that she's actually using, the amount of opioids she's using, the amount of benzodiazepine she's using, and find out sort of the frequency of the dosing of these opioids, whether how many times a day, whether she's waking up at night to get it. I also want to know stuff like what's the quality of sleep. I want to know more about her mood issues, whether or not she's depressed at the moment, whether she's been depressed in the past, any suicide or overdose attempts, either accidental or on purpose. And then I'd also want to know, part of the clinical assessment is a physical assessment as well. Now, in a person who's otherwise well, how is she dressed? Is she dressed shabbily now? Is she starting to let go of herself? What's her dental status like? What's her skin like? What's her general body language like? Is she shaking? Is she avoiding eye contact? And then once you go into the boundaries, well, I guess a lot of that will really depend on the on her mental state and how she presents, whether she's in a cooperative sort of state, whether she wants to actually do something about her problem more than just lip service. Is someone pushing her to come to the consultation? Someone commented before, any forensic issues? Is there a legal reason why she has to come? Is it purely to save her job? Are there issues at work that are forcing her to come? And I guess once you've gathered a bit more data, you can do those boundaries. But certainly I think it needs to be made clear, as everyone would agree and everyone would know, is that this is basically the end of the road for this type of substance use in terms of what we as a medical profession and support workers, drug and alcohol colleagues, would want to offer this patient. So the boundaries are, the buck stops here basically, so what are we going to do about it?
Cameron, you want to go for the boundaries part? Rob ignored it. So.
He kind of did, but I guess the thing that I'm still not 100% clear on in her is, and the purpose of the first consult is to try and work out what her agenda is, what she thinks the main problem is, and for me to then tell her what I think the main problem is after an assessment, because in that it's going to become very clear what my boundaries around prescribing and a therapeutic relationship and engagement with her would be. So she's kind of got this mix here. She's telling me it's about anxiety, but she's using all these opiates, and I want to tease out whether she sees that there is this drug dependence sitting there, as well as a possible psychiatric disorder, and whether she actually sees it's a problem and whether she's actually coming to me for help, or does she think I'm just going to give her a script for codeine and send her on her way, which of course I'm not going to do. I think that was the answer to your question. You're looking at me very suspicious.
No. I don't think. Look, I don't think there are obvious. I mean, there's some obvious answers, but I don't think there's correct answers. It's about what priorities were put in place, and I suppose some of it really is having a priority in terms of what's important right now. What can I wait and defer for another session, and really again setting up some agenda items and working out. I'm at the moment a GP who've got limited ideas of where she's coming from. And you're alluding to basically finding out where she's placed. She's obviously been sent from the pharmacy. How voluntary is that? What other issues are there? What I might do, just to further discussion, we'll just go through the next couple of slides and just go through what, in general, not necessarily for Mel, or Mel, this would certainly apply, but basically you need to look at the initial presentation for someone like Mel and work out why she's actually presenting and what problems relate to that. So what was it about the pharmacist itself? Did they just say, see a pharmacist, I'm not going to give you any more, or were they alluding to a certain problem that she may be having that they've assessed? So that presenting problem can certainly give you some levers to work through her subsequent issues, and also link possibly some physical things and psychological things to her presentation and make it more valid for her rather than just bringing up other issues that you may not feel that are relevant.
Well, I think also one of the other key things at this stage, which doesn't come through when you look at a case history sheet, is the patient intoxicated at the interview, or are they in withdrawal? And if they are, how severe is that withdrawal? Because that's going to influence a lot of the answers and a lot of the further interaction that's going to take place in the consultation.
Yeah. Now, just to take away from the content for a second, I just noticed a few attendees have put their hands up, and I'm going to put all hands down now, so you can put your hands down. If you've got a question, please put in the question thing, because we actually don't know what a hands up actually means. So I'll put all hands down. So try and avoid the hands up little icon thing and focus on just asking a question if you've got one. That makes it much easier. We can certainly share those questions with everyone if they're appropriate. So the next point on this slide basically looks at linking in whether drug use relates to the presentation. So sometimes people present with for example, just the anxiety and not necessarily this whole pharmacy medication thing, and then making a link between the possible drug use, whether it's the effect of the drug or the effect of withdrawal of the drug, whether it's related to the anxiety, and some of it takes a bit of time to assess. Cameron alluded to the motivation for presentation, and I think really important to engage your patients at the level, but you need to assess what the level is before you can engage them on that, and whether there's further concerns. The next slide talks a bit more about assessment of the drug use itself. And so really have to focus on every class. It's important not to neglect common classes. So while we're looking at the moment, benzos and we're looking at opioids as primary things for Mel, not forgetting other things she may not have mentioned. So even mentioning things like cocaine, which hasn't been mentioned so far, but just asking about a history of that, because some people will have a bit of stigma about those things and may not be willing to open things up. So certainly going through all these factors per class, and for panel, which one of these would be the most important for you? If you had to ask one only, which one gives you the best bang for the buck?
It's unfair.
It's unfair, but I'm running the show, so one. Which one?
One only.
Which one do you think?
I would agree with the other panel members on that, despite wanting to create some controversy.
I think as one, that should be
all of it. You can't decide.
Yeah, well, that's going to be a branch
well.
point for working out which sort of direction you're going to go into in further treatment or treatment options.
Cameron? It's a false question.
Yeah, no. Quantity, frequency, and pattern. I want to know how big a problem we're looking at. If I had to choose one, and I think the question is unfair, but that's okay.
Yes.
But number 3 is actually part of number 1 too.
Yeah, kind of, I suppose.
Frequency, duration,
pattern. So for me, it's the last one, the functional things, because that tells me a lot more about what the effect of the drug use is on the patient. Because to some extent, the rest of it for me is irrelevant. If they may have small quantities and everything, but if it's a massive functional deterioration, that gives me my severity from the start. Again, we don't ask one question, but I just wanted to put you on the spot, and obviously some of you came to the fore and some just shirked the issue, but that's the nature of general practice, isn't it? Sorry, guys.
So you're the psychiatrist.
I'm the psychiatrist.
And some other of us are more broadly based.
Yeah. So let's go through a little bit more history here, and look at Mel's actual drug use once we take that more thorough history from her. So I'll let everyone have a look at this. This is basically a 7-day, fairly accurate history. Now, it's taken a while to get to this history from her. She wouldn't have given you this necessarily in the detail you've got, but let's assume we've got that detail, maybe from the pharmacist, maybe from her after developing a bit of rapport. But just have a look at that and just try and see what's involved in the doses and how they change over the week. Now, remembering, a lot of this is non-prescribed. So some of it is certainly over the counter, and she's getting this from her friends, so she's buying it from her so-called friends, rather than actually doing any further doctor shopping. So she's sort of finished her doctor shopping phase of her career.
So Sindol is really the only OTC that she's using in this cocktail.
Yep, that's got codeine in it.
And that's got some codeine in it. So but the thing that really jumps out at you are the benzodiazepines. And that would be, I mean, in the sort of work that we would see in day-to-day practice, that would be a reasonably small opioid habit.
Yeah.
We haven't clarified whether there's alcohol in any of that.
Yeah.
And that's just one comment to add.
Absolutely.
It should be part of the questionnaire.
Yeah, particularly given that benzos are a GABA drug and whether she's got any other sort of GABA active stuff running through.
And whether or not she's smoking any cannabis as well at night to sedate her.
So the history here is no current cannabis. It's basically
Mm.
just these medications, and no alcohol is no longer in the picture to the extent that she's using it.
Substituting with other drugs.
Absolutely.
So is day one Monday?
Don't know. Maybe. What?
I guess the reason why I'm asking, I'm interested to know whether the large volumes of use are a result of her getting paid the day before, or the higher volumes of use the start of the week. She may actually be not coping at work, and she's self-medicating for that. I mean, it's an unanswerable question. It's still something I'm interested in.
Or maybe she controls herself during the working week and day 1 and 2
So
of
the weekends. Yeah,
So I know a little bit more about milk. I'm going to give you the answer for that, the question. So obviously her use is quite sporadic here, and it's largely dependent, according to when you ask her, when she's able to purchase it. So it's purely a financial thing.
Payday
She's
thing.
got more money, she can buy more. If she can't, she basically pulls back on what she's got left at this stage. The OxyContin, by the way, is generally the 40 milligram dosing. So the top line there continues all the way down. It remains at between 1, 2, or 3 tablets of the 40 milligram dose. And this is basically her most recent use. So we haven't got days of the week, but yeah.
So it's an erratic pattern is a comment that I would make on looking at that. The other issues that I'd be starting to ask, I'd be getting into the social histories, what else is going on in this person's life, because when you've got a pattern like that, there's a lot of actual things that are going on where they're using various different drugs during the day and during the night, whatever they can get their hands on. Why are they needing to go out and do all that, etc., etc. And we really need to hone down and try and actually point out to them that there is something else going on except for chasing substances all day. And I'd also make the comment that it's important to discover whether or not these medications are being prescribed or they're being acquired on the street from the local drug dealer.
So she described earlier that she's basically shifted from doctor shopping to getting it illicitly from friends in whatever mode that is, and identifying that doctor shopping was going to possibly cause her an issue with the authorities in terms of being caught out. What are the risks of getting it from illicit sources like neighbours and friends and family? Is that a safer, or is she harm minimised, or is she harm maximised in terms of her approach here?
Well, we don't really know if it's just family and friends. I mean, if she's buying it on the street, well, she's obviously going to be coming into contact with people who are involved with criminal type activities. So you've got all the harms that are involved with that in terms of standover tactics, in terms of blackmail, in terms of being ripped off, in terms of being assaulted or having things stolen from her, having her house perhaps revealed to people who can come around and stalk her for money that's owed. These are common things that you see people are involved, in illicit substance use. And in terms of getting it from family or from friends, is this harm minimisation? Well, I guess you could say no, because she's just perpetuating the problem. It's harm maximisation, I would have to say.
Yeah. Any other thoughts about that?
I think that it's quite significant harm. In particular, she's getting multiple different types of benzodiazepines.
Yeah.
And she may not necessarily know how strong a 2 milligram tablet or brick of alprazolam is, and may think that it's not that sort of 40 milligrams of diazepam equivalent that you've listed. So now she's taking sort of 75 odd milligrams of diazepam equivalent on day one, which is a pretty damn big slug of benzodiazepam.
So Karen, just how did you get to that number?
Temazepam is about twice the strength of diazepam.
No, number per number. So
Per number,
okay.
number to number. So I'll say that's worth about 20 milligrams of diazepam. You've told me that there's 15 milligrams of diazepam, and you've also been nice enough to tell me that 2 milligrams of alprazolam is equivalent to 40 milligrams equivalent of diazepam. So it's just a simple sum.
Yeah, that's right. But just worth pointing out, because it's worth combining a class into a single sort of figure as much as we can convert accurately. There's not a lot of accuracy with conversion tables, but to give you a better idea of where things are, because otherwise you can sort of lose yourself in a lot of this itself.
The thing that, just going back to the sort of the pattern of substance use and what we know about, the fact that she's working full time, but dividing that between chasing around trying to get drugs, it really shows that you've got someone who's barely hanging on by the skin of their teeth. They're hanging on to this job desperately as the only point of stability, and then there's this massive chaotic pattern of like random sporadic substance abuse. So she's struggling.
And is she in fact hanging on to her job, or are her employers in fact silently aware of what's going on and very conscious of the fact that if she does lose her job, that may be the end of her? And that's a real question to ask and to explore as well.
Yeah. I've got one more question for the panel on this slide, but again, reminder to attendees, if you've got a question or a comment about these things, please just write in the questions box, and we'll certainly share those questions and aim to answer them. So the question I've got before we move on to the next bit is, we've talked about, we've got how many classes of medications are on this list?
Well, there's three. There's benzodiazepine,
Benzos,
there's opioid,
Yep.
and in the Mesindol there's doxylamine succinate, which is an antihistamine.
Yeah, okay. So the combination of those three, what interactions would you be concerned about or considering if you're looking at the drug interactions?
So the magic word you're looking for is synergy, rather than adding the sedative effects. And with all of that drug interaction, perhaps you're going to be prolonging the half-life of the benzo through the doxylamine, and who knows what the metabolism of the opiate will be. When we're talking about Mesindol, she might call it Mesindol, but it could be Mesindol Fort. So 6 tablets of Mesindol have a varying amount of codeine in it. So I get particularly uncomfortable when I see more than one drug in one class with differing half-lives. I see that as a recipe for death. And I frankly talk to the patients and explain to them the coroner's concerns. And in fact, sometimes I even have to talk to my colleagues about that who appear not to recognise that. And I think that if we're actually objective and sensible about what we're doing, we need to rationalise if we are prescribing these classes down to one from each class. I hope I've answered you, Paul.
Yeah.
I think the other issues are, like, generally speaking, the benzodiazepines and the opioids, they tend to interact with each other, and one can prolong the half-life of the other. There's also a phenomenon that people who do a lot of opioid prescribing, particularly pharmacotherapy, are aware of, known as combined drug toxicity, and I think that this was what Michael was suggesting before. It's basically where the whole is greater than the sum of its parts, essentially. So although a person might have a certain, let's say, therapeutic or high level of opioid and a therapeutic or high level of a benzodiazepine, the combination of the two can actually cause death, even though they are in so-called therapeutic levels, because the two are additive, and the effect, unfortunately, on respiratory depression and also on terms of prolongation of the QT interval, which is often thought to be a cause of death. Even in people who have been on these combinations of substances and you think are quite stable for many years, it can still be a cause of death. So respiratory depression, cardiac arrest due to combined drug toxicity, even though the actual numbers of the drugs, the actual milligram dosage, might not seem to be so great.
I'd agree with that, Rob.
Yeah.
So
That's true.
if we just go on to the next slide, there's a bit more of an assessment rather than just the drug use itself. And so there's this comorbid assessment that goes along, which I've alluded to a little bit earlier. And we're looking at both, the biopsychosocial approach, I want to use that term. How do you do this? How, guys, your GPs, how do you do this routinely? We haven't got the psychiatry hour. We've got shorter consultation times. How do you get this assessment happening within the constraints of general practice?
That's the art of medicine.
Yes.
That's the science.
Tell us about your artistry then, Rob.
It's the gestalt. Well, you have to be very, very alert in terms of looking at the way the patient dresses, as I mentioned before, the content of the speech, whether there's any speech pressure, whether there's any sort of delusional type ideas, whether there's any paranoia, whether there's any references to any sort of auditory type hallucinations, if there's a tremor, a lot of picking at the clothes or picking at the skin, whether they're in withdrawal. And you really have to also ask the question, have you tried to commit suicide before? Are you depressed right now? You have to ask the question.
So
So
the good thing is that I don't have to do this in one sitting. What I need to do straight up is be fairly nimble in my questioning and try and work out where the big risks may be. Like Rob has said, is she actively suicidal? Is there a significant enough mental health problem that she's going to be at risk in the immediate term? Is there a physical health problem that she's going to be at risk in the immediate term? Is her social functioning so completely chaotic that she's going to be at risk when she goes home? So I guess there's the immediate safety issues and the immediate major big letter health things that I need to work out, because the rest of the stuff, if she chooses to engage in treatment with me, I'll find out over the coming consults. I don't have to do everything in one sitting.
Yeah. I'd just add to what both Rob and Cam have said. The beauty of general practice is that it is like a piece of art. You can just keep adding to it and slowly developing it and making it three-dimensional if you so choose. And the issues that you've got to do, as has been pointed out, you've got to assess the safety. You've got to establish the depth of the problem. You've got to cover off on those three headlines: the physical, mental and social, superficially in a safe manner, and then look towards what's driving it all is my way. I think that I would simply answer that comorbid assessment, and then you spend the next few months actually helping the patient solve their issues.
I like to think of drug and alcohol topics very much like any other chronic disease, although the psycho and the social aspects often far outweigh the physical, as opposed to something that, say, like diabetes, which we're often focusing on the physical. And there are psychological and social aspects, but the balance is different. But the broad approach is very similar, and we don't try and assess and cure the patient and do everything within the one consultation. It is basically, what's the priority here? Is it a ketoacidotic and as a diabetic? Deal with that and then work off there. If that's okay, what's the next most pressing? Is it engaging the patient? Are there the health parameters as Cameron's alluded to? And I don't say this is much different. You've just got to take a similar framework with what you're very familiar with, and just a slightly different, a sidestep into a different clinical topic. But the approach is very similar. I think the key here is really considering the psychosocial aspects a lot more so than just the physical. But this is one clinical area which affects all of health across the board.
Although I would like to add, even though the physical emergencies are often substantially less, there are a lot of physical issues that need to be identified, and at times they are urgent. Essentially, when the patient staggers in and they're looking pretty grey.
Febrile, injection sites, noisy heart.
Well, you may not diagnose all that. It could be osteomyelitis, or a serious
medical condition.
And they do present, in a patient such as this as well.
When I had a patient today who came in for the first time requesting help, and part of my assessment, we had a double appointment, thankfully, but I was just doing a blood pressure, and she said, "Oh, please just choose this arm," being her left arm. And because she said that, I said, "Oh, why not this arm?" Thinking she had a bit of embarrassment. She goes, "Oh," and she wasn't so much embarrassed about the injecting site, which was the issue, but it was about the abscess that was forming behind it. It was too sore for a blood pressure cuff. So only fortuitously did I pick up an abscess that could be treated today rather than left till next week, which is going to be a bit of a disaster. So sometimes you find these things out without planning to, and don't feel guilty if it comes across fortuitously. You just got to deal with
your blood pressure, doctor?
Well, actually, it was something that I was comfortable treating and looking at, so I was quite pleased that it came up rather than having to discover it down the track with some sepsis or whatever it may have been. But yeah, certainly there's competing priorities, and we've got to balance those things. How do you assess her motivation? So Mel's come in. The story is that you've got this background story, but the story is she's been sent from the pharmacy because they won't sell her anything else with a GP assessment, whatever that means. how do you assess where she's at, her motivation at this stage?
So I'll jump in on that, if that's all right. I'll actually turn it around to the patient and say, what do you want me to do today? How can I help you? And through the very open question, you'll actually answer a lot of that, and they'll tell you appropriately or inappropriately. And often they're talking for 5 minutes.
Any other words we use? Any phrases or anything else you can remember? I mean, I've used the term, how do you feel about being here today? It gives me a very clear picture of how they actually, how comfortable they are seeing me. Is it being coerced? Do they feel like they're pressured, or is this something they want to do? Opens up a similar discussion, but a number of ways of opening these things up, and I think it's an important question to ask very early on in the piece.
Who sent you here?
Yeah.
Is another question early.
What were you hoping that I would do for you?
Yes.
Well, that's a bit aggressive, but still.
Well, I've asked in a similar way where while you're in the waiting room, because they're invariably waiting a little bit of time for me, while you're in the waiting room, what were you expecting to get out of this consultation? So not about me, but about the consultation. And they often say, well, I just want to get the court order letter for support, or I only want this or that, or actually, I don't really know, but I'm here to get your advice. They're a bit more open. So just, again, open those questions up very early, and certainly helps you focus. So now I've got a couple of questions coming in here. But someone suggested, Nayana's often asked, what made you come to see me today? Similar to your question. And a question from the previous slide, should we be monitoring or checking QT intervals routinely on those with combination opioids and benzos?
There are people that, I guess it's how Casey, yeah, look, that's a really difficult question. Yeah, it just depends on how many people have died on you and how many times you've been to the coroner's court or written letters.
Ideal world.
There's really no guidelines as to whether or not we should do an ECG on pretty much everyone on an opioid plus or minus benzo combination. However, I mean, I guess a baseline would be if you've got anyone with any sort of cardiac history or significant risk factors, that should certainly enter your thinking.
I think for me, the only time I really start looking for this more thoroughly is when I've already know the QT interval from another reason to do an ECG, or if there's a family history of a sudden death, especially in a younger person. My cousin was playing football and just died. That's a red alert for me. There's something possibly in there.
Arrhythmias, congenital heart disease, those sorts of
But you certainly wouldn't be routinely screening everyone with an ECG, just routinely.
It's got to be targeted.
All right, so we'll move on from the history part of things, and again, examining these are. I mean, examination of patients should be fairly broad, but these are aspects that I've picked out here that are probably more pertinent for certain drug and alcohol presentations that you may sort of miss. I mean, you certainly wouldn't be looking at injection sites necessarily with other patients with other chronic diseases, but so general things, just one for each from the panel. What give me a general subtopic? What's something you could look at just generally that maybe
just their body movements in the way that the patient's actually sitting there, or if they're not sitting there, whether they're scratching, whether
general
they're
appearance.
shaking.
Yep.
State of alertness.
Yep. Okay. Yep.
The amount and distribution of injection sites. If they've got them all over their necks and in their arms, you've got quite a different problem.
Absolutely, yeah. I think the colour also can tell you a lot of it, partly nutritional state, but anemia is not uncommon. Jaundice uncommon, but a serious complication.
But also, I was going to say, people who are on opioids, who are using opioids, they often have this greyish sort of grey sort of palette to their skin and a fine film of sweat.
It's interesting. Most people will actually try and clean up when they actually come to see their doctor. So somebody who actually turns up frankly intoxicated is telling you a lot about the amount of drug chaos that they're sitting in.
I think there's another thing that we should think about including there, as well as those important things, is something that isn't really written in the textbooks. And when you're assessing one of these complicated patients, it's actually important to ask yourself a question: what are they doing to me? And the answer to that question can actually help you learn a lot about what's going on within the patient. So if they're really annoying you, it probably means that they're a person with a personality disorder. If their attitude is intrusive and aggressive, they may well even be antisocial. And you need to really quickly work out what is going on within them so that you can actually manage them appropriately. So as the hidden general assessments are going on, you've got to just try and work out what is actually wrong with them psychiatrically that's led them into your office and given them this blessing of polysubstance misuse and all the other things that you need to work through.
I think the other thing too is anyone who's got an opioid sort of story, look at their pupils. Generally, you can just quickly look at their eyes, constricted and pinned, then they're intoxicated, dilated, they are actually in withdrawal, and that gives you an idea also in terms of what sort of immediate treatment you might want to offer them.
Yeah, it doesn't apply to benzos or alcohol or other classes though, so
no, unfortunately.
It's a useful sign, but opioids only.
Yeah.
Thankfully for that sign, opioids are common enough that we often have to assess it regularly.
Yep.
Yeah. I've got another question here before we move on. So what sort of response would you give if a patient says they are there because they have to, as opposed to them seeking help themselves? So the one that's not really motivated for treatment, but motivated for attendance for other reasons, for third-party reasons, for example.
Well,
what sort of response?
My question is, okay, let's find out the answer to that question. Maybe motivated by the court, maybe motivated by the parents or whatever. And you know that you're not going to get very far past whatever goal it is. So as soon as the parents leave the room, they'll disengage if it's a parental thing. If it's the court case that's forthcoming for whatever reason, it could be a custody access visit, it could be a crime that they committed. If they're not motivated to get better for themselves, I actually point that out to them and tell them, quite frankly, court will come and court will go, and court will come and court will go. And if you're not going to fix yourself for you, the judge will remember you one day and you will go on a long holiday and then you'll come out and it's up to you to decide whether or not you want to take control of your life. So exactly what Paul's asking is an important question.
But actually it was Jackie asking. Thanks, Jackie.
Oh, sorry. Thank you, Jackie. But you've really got to work out the motivation and actually illustrate to the patient that unless the motivation is driven by themselves with all the benefits outside of themselves, they will not achieve. And you can waste a lot of time on people who don't want to get better and achieve very little.
You know, the comparison is the middle-aged man who comes in and says, oh, my wife told me I had to come in. You know, it's trying to determine motivation is not really all that different from that circumstance. Do you see the problem? What are you worried about? Why do you think that she, he, the pharmacist, the court, your parole officer is worried about you? Do you see that there's any validity in what they're actually saying?
I think at the end of the day, though, you know, as the GP, you're still going to say the same thing. You're going to give them a summary of what you feel are the main issues from the doctor's point of view or from what we see as the health professional's point of view, and just put it to them, well, these are the issues that I feel, you know, we should address right now. These are the issues that are having a significant health effect and damaging your life, and I believe you should do X, Y, and Z now, and then later on we'll look at this. Would you like to get involved in this sort of treatment plan? And that'll really pretty much sort out the wheat from the chaff at that stage.
So I reckon that's a really good point. At some point, actually calling them on it. You know, after everything you've told me, I think you've got a really big problem with all these drugs you're taking.
Yeah.
To actually call them on it, to put some point in their head that, you know, we're seeing a problem.
Yeah. Well, I'm just summarising this. So right now, everyone else can see the response in a text format as well, or at least my summary of things. Now, there's a really good question from Ike. I think it's Ike. Sorry if I pronounced Licky. No, it must be Ike. And it's an important question for often those that are less comfortable with the drug and alcohol sector sort of work. The question is, how do you avoid being judgmental?
I think it's quite simple not to be judgmental, actually. I don't think that's a difficult question to answer at all. I think you just go back to your, you go back to your medical training, just like you don't judge someone who's got a chest infection or someone who's got diabetes. This person's got a problem that has a lot of medical aspects to it. The problem's medicalised in our particular in our particular paradigm that we work in, and we just treat it like we would any other medical problem. Here are your issues. You have a problem with opioid abuse. You have a problem with overusing benzodiazepines. And these are the motions that you need to put in place. These are steps you need to put into place to sort out your problem. There's no room for being judgmental. If you're being judgmental, you can't treat this patient properly, that is.
Yeah. Agree.
Think of it. A lot of us have been trained in countries that have very different cultural paradigms, and even within Australia, different generations have certainly different expectations of this whole sector of drug use. It used to be not even a medical issue. It was all very much a social and a legal issue, and there was no medical role. And so things have certainly changed over a number of years. We've got to maintain that this is very much a medical issue with social and other issues. And like every other medical issue, we've really got to take our own biases out of the room as much as possible and treat the patient on their own merits. As Rob alluded to, you really can't treat the patient properly being judgmental and second-guessing their motives and things. Doesn't mean you take everything on face value, because they're still sorting you out, you're sorting them out. But to some extent, it's really important to try and remove some of the language, like calling someone addicted, which is certainly, it may be correct, but it's certainly got certain connotations that will put people offside, and just and some of the moral things, to some extent, whether someone's taking a drug, prescribed drug, so MS content, prescribed, or whether they bought it off the street or from a drug dealer, it's the same drug, it's going to have very similar effects. The only issue there is the legality of where they got it from, which we're not the police, but the legality may give us extra things to look at in terms of courts or police issues themselves. So we've got to take away some of the moral issues out of the picture, put them aside, and maybe bring them up if the patient has an issue with them down the track.
When we start thinking about that sort of us and them stuff, it's probably somewhat useful to think what someone said to me once, that so many of us are about 4 paychecks away from being homeless. Or indeed, we're probably one significant injury away from a big risk of falling into the trap of pharmaceutical misuse. And there was a really good practical example that an addiction specialist does once, where he asks the audience, who in the audience has ever been in an emergency department and required morphine for something, broken leg, car accident, whatever the case may be? Usually about half of the people put up their hand. And then he says at the end of that, of everyone with your hand still up, who actually really liked it? And what's really interesting, about half of the people will keep their hand up and will describe this enormous sense of euphoria and feel-goodness with the dose of morphine for their broken leg. And the other half will just go, it made me feel absolutely revolting. And when you start thinking about things like that, there's a lot of us that actually aren't that far away from the situation that some of our patients in drug and alcohol circumstances get to. So there is absolutely no place for us to think of this group of patients as some abstract them. Rather, they are an us, and they're us, and they're our brothers and our mothers and our daughters and our sons and our friends, just the same as somebody with heart disease or diabetes or epilepsy or hypertension is.
I think another thing to also think about as you're sort of digesting your role in patient management is thinking about how you deliver diagnoses and facts to patients. For instance, telling a patient they're an epileptic or telling them they're a person who suffers from epilepsy, similarly with diabetes. So it is actually the delivery and the non-prejudicial nature in what you're doing. You're actually trying to be a doctor rather than lecture them. And I think bringing down the walls is as important as anything else in trying to destigmatise and do all of that.
There's a question I will just hold off. So Conrad, your statement, I'll just hold that before. Actually, I might flick it to everyone else but the panel. So there's a statement. I just want to see what your reflections are. And I'll make it into a question. Is it our responsibility as GPs to fix the prescription drugs that were legitimately commenced by our own profession?
Well, I would say that if the patient's attending you for their medical problem, it doesn't matter whether a drug dealer has given it to them, it doesn't matter whether it was prescribed in hospital by a pain specialist or by another GP. You have a patient there with a specific problem, and you go back to your professionalism. You respect the patient, you are non-judgmental, and you offer the best medical advice you can. I don't think it's very good. I don't think it's very good form to go bagging other doctors as well who prescribe poorly, because we're all easy game at the end of the day. For very many different authorities or for many different experts and many guidelines that we're all supposed to adhere to. I think you really need to go back to your basics, be professional.
And in another way, although general practice isn't entirely responsible for the misuse of pharmaceuticals, because of the number of general practitioners, a lot of the pharmaceuticals that do get prescribed and misused are coming off our prescription pads. So in that, this is absolutely a problem that general practice should fix, because it is a problem that is coming out of general practice. But I do agree absolutely with Rob saying, is that this isn't a time to just go and bag other practitioners that are also trying to do their best.
Can I add that what we're trying to deal with here is a polysubstance problem, and that's what the patients come to you for. Now, if you're sharing the patient with another practitioner who is actually prescribing them, say it's the consultant psychiatrist, this is a real case, who's prescribing 3 different benzos and 2 different antidepressants to a patient, and no opiates, however, and the psychiatrist turns around and says to you, well, I'm just going to hand the patient over to you. And you think, well, hang on a minute, you've been looking after them for 10 years and that's inappropriate. And it's not unreasonable in that situation, I believe, to actually call the specialist and say, hey, you've created this, so you're going to manage it now. You're not going to dump it on me. And I suggest that you rationalise your prescribing, and if necessary, you have other alternatives. And we know what those alternatives are. Let's get involved a pain management team. Let's perhaps consider admission into a hospital to sort these things out and utilise a team approach, not just use pharmacotherapy, but also physical therapies and so on and so forth.
So just because somebody else has prescribed a medication does not mean you have to continue to prescribe it. The orthopaedic surgeon prescribing the big giant fentanyl patch does not mean that you have to just continue that fentanyl patch without your own judgment, your own responsibility for every script you prescribe.
Thank you. We'll come back to Mel. I want to ask the audience now,
More polls.
what category would you put her in if you were to label her? So again, writing down 1, 2, 3, 4, or 5. Substance use disorder only, substance use plus anxiety, substance use plus a masked depression, anxiety plus or minus depression with no substance use disorder, or really, I've got no idea at this stage. For those that have arrived a bit later from the start, we're talking about a case called Mel, and you can access Mel's case from the handouts part of the panel of the webinar application. So you can look at that if you already haven't or sourced it. Right, just getting up to 2/3 of you have committed to something. Now, by the way, this is all anonymous, so you don't have. We're not going to pick on you because we don't actually know who's responded to what.
Some people are watching.
No one's watching, Cameron. Well, we're watching the screen, but they actually can't tell who's voting. So completely anonymous from that point of view. So feel reassured just to, if you've got no idea,
I
write
should
it down.
vote there. It's anonymous.
All right, we'll give it 5 more seconds. Okay, we'll close that and have a look at what the poll was. So we had 5% as number 1, 5%. The majority picked number 2, 57%. Just under a third suggested it was number 3. No one thought there wasn't a substance use disorder, very intuitive of you, but 10% were honest enough saying, I've really got no idea at this stage. So thank you for answering that part of the poll. And we're just going to move on because I think everyone, apart from number 5, suggested that she had a substance use disorder. Is it mild, moderate, or severe? So we'll open the next poll. So we'll just wait for the poll to come up on the screen. And then 1, 2, or 3 to work out where you think she's at, mild, moderate, or severe. And this is a spectrum. So there isn't necessarily an absolute right answer, but we'll guide you through this.
While people are thinking, Paul, I'd just like to add that the way that this webinar has been developed is really quite good with the enhancements that have been made. I'd like to congratulate the college and yourself through the work that you've done in developing this.
Nothing like a bit of backslapping halfway through a poll. Thanks, Michael. Now coming back, we've still got about 2/3 have voted. And again, if you're not sure how to vote, it's not on the question panel. It's actually by using the number or tapping, if you're using a touch device, tapping the response that suits you best. Okay, we'll close that now. So we've got 30% suggested moderate and 70% suggested severe, and no one actually clicked on the mild part of things. So the term substance use disorders now in DSM-5 rather than opioid or benzo dependence disorder. So substance use disorder, it's a spectrum now, rather than sort of dichotomous, you're dependent or you're not. And there's some subtle language change, and one important extra factor that didn't used to be in there is the idea of cravings. So we can now utilise cravings to things. So here we go on the slide. So there's 10 different points there. Now I want to make a little point. Points 9 and 10, tolerance and withdrawal, according to DSM-5, are not criteria you measure if it's a prescribed medication for this patient. So you would only use the first 8 criteria, but if it's a illicitly sourced, so something like an illegal drug like heroin, or if it's the OxyContin and other drugs that Mel's using, which is sourcing it illicitly, then you would use all 10 criteria. So it's got that funny little quirk in it. The more of these, the more severe you are. So if we just go through, and I'll ask the panel one at a time, does she qualify, Rob, for number 1, taking amounts in larger or longer periods intended?
Look, this is a really, really interesting question because, you know, there are 2 substances. So on one substance, she's clearly got a severe issue with the benzos. And with the opioids, in the general scheme of things, in comparison to someone who's using a lot of heroin, street-based type opioids, it might be a mild to a moderate, given the sort of quantities that we see some people use. But I guess in her case, she's able to function in terms of her work and function in a limited social way.
Question 1 first, or point 1. Has she taken larger amounts or for longer than she would have originally intended?
Well, I would imagine she quickly escalated to a particular point. Yeah. She's pretty much plateaued.
Yeah, she's plateaued now, but she certainly started with just some over-the-counter stuff and escalated from there. Cameron?
Is there a persistent desire or unsuccessful efforts to cut down or control substance use? We don't know the answer to that. However, she does do that throwaway statement where she thinks that she's in control of her codeine and OxyContin, which I actually think is complete and utter nonsense, given that she's taking, I think there was a couple of days where she was taking 3 by 40 milligrams of OxyContin, which is 120 per day, morphine equivalent, that's 180 milligrams of morphine equivalent a day, which is enormous.
Yeah.
Because the risks of death once you get over 100 milligrams of morphine equivalents per day skyrocket.
But we really can't assess that second point because we haven't asked the question.
We don't know.
So we need to ask that question as part of it.
But she doesn't have the insight to know that she's got some problems.
Michael?
Sorry.
Has she spent a fair bit of time sourcing her drugs?
I reckon she has, so I'd say a tick for that one.
Yep. You can go number 4 now, you're on a roll. Any history of cravings or?
I think this lady, to be quite diplomatic here, I think this lady was born with cravings.
But we haven't asked her.
No,
so we can't yet.
That's what I think.
Yeah.
But
do you think she would have cravings from the history you've got?
I'm sure she's got cravings.
Yeah.
But we haven't asked.
No, but we need to know.
Rob, is she continuing to use despite help? Sorry, we're waving our hands vigorously because the lights just went out. Here we go.
Well, we don't really know that much about her social or interpersonal problems.
So she's still got a job. She's got social, stable housing, so it doesn't sound like that's affected yet. So not sure yet.
Not sure yet. Yeah,
Do
we
you
don't
think
know.
patients like her? Do you think they, at this stage, given that she's got good housing, relatively, if she's still employed, have likely to have had problems in that regard?
I think so, even despite all of those relatively stable underpinnings.
So a GP asking this should expect, if they're asking in a good way,
Yeah.
a response that
Something.
explores a problem. They shouldn't be expecting there to be no problems at this stage, unless the patient's not has an insight or isn't really engaging it.
Absolutely.
Okay. Has she given up or reduced any important social, occupational, recreational activities?
Well, we don't really know from the history as been given, but it just seems that she must, in terms of the amount of running around she does to try and balance everything together. So you have to imply a lot of things here.
Yep. Yeah.
Can I just add to that? It could become her life. And you could argue that is her life. She could be a professional dealer.
She could be a
and
dealer too.
Yeah, we have
and
history.
this may be all of her recreational time and what she wants to do full time. She may derive an income from it.
Yep.
So it's an interesting question.
Now, this number 7, recurrent use in situations where it's physically hazardous. What does that mean?
Well, it's like driving.
Yep.
Is
Under
that
influence.
injecting under the bridge?
Oh, yeah.
That would be physically hazardous.
Or on the edge of the
But then
bridge.
do you also then include...
Injecting alone?
Yeah, do you also then include her taking these drugs alone with other people in the house, with babies in the house? Does that sort of bundle end up physically hazardous? I don't know.
No,
I
it's
think
more
so.
hazardous to themselves.
Hazardous themselves.
Now, we haven't got a history of injecting, by the way, so this could all be, and it often is oral intake.
But do we need a history of injecting, Paul?
Only for the complications related to that, not necessarily.
And in other professions,
Still die from
Absolutely.
oral ingestion.
in other
Absolutely.
occupations, things like driving heavy machinery and all that sort of stuff would be in that sort of
It does come down to the threshold of physically hazardous. Though.
And the next one's sort of related with the
Semantic.
other parts there. Has she continued use despite having previous psychosocial,
Well, that's an
physical
interesting
harm?
one because she feels that these drugs are necessary to treat her psychological problems.
So perhaps with
an
insight,
issue.
then this may come about as a positive factor there. Will she be tolerant? Her dose changes every day.
She's got a baseline high amount of these substances that she's using on a regular basis in order to maintain a level of function. I would suggest if anybody here in this room took a smidgen of that, they'd be up to date.
It would be an interesting question to find out how much, or if any, withdrawal symptoms she gets on the days where she can't afford as much drug. But we have to ask those questions. We don't really know.
Yeah.
So the other thing is as well that you'd have to assume that on her work days that she takes the drugs mainly in the evenings because she's still functioning and she hasn't been booted out. But the other thing is too, diminished effect with continued use of the same amount. Well, she's just got more and more anxiety.
Yeah.
So, that anxiety really is she's not getting enough of the substance.
Yeah. Certainly, I mean, she's certainly got tolerance.
Yeah.
If she started her drug use career with these doses, she may have died then. So she's developed tolerance to be able to tolerate those doses.
Absolutely.
I'm sure if all of us here had those an hour beforehand, we wouldn't be having this webinar. We'd be either asleep or unconscious
We might
or
next
dead.
week.
Yeah, it'd be a very slow webinar.
And if you treated her thyroid nodule that was getting her into this state, you might find that her tolerance would substantially decrease.
Yeah, so again, that broader exploration shouldn't be just narrow focused on just an addiction where the other things can be intervening and interacting there. Now, withdrawal, what symptoms would you expect? She's got benzos and opioids as her main drugs. If she was withdrawing, what clinical picture would you expect to see in front of you?
Anxiety would be in this particular case.
But I'm treating that. She's treating her anxiety. It's just she's undertreated, surely.
And there we go. So therefore we need a bit of health education.
Okay. Yeah. Apart from anxiety, any other symptoms?
The sweats, the pupil dilatation from the opioid withdrawal, she'd have tremor most likely, hypervigilance. I mean, all of those standard textbook things. Yeah. But you'll also find if they're actually getting into a more advanced withdrawal, plus or minus those symptoms, a bit of aggression and transference coming over as they get more agitated than anxious.
And the classical runny nose, watery eyes,
diarrhea, vomiting.
Yeah.
So apart from anxiety, you mentioned, which ones are benzo specific rather than opioid specific? Are there anything else? I mean, anxiety can be both, obviously.
Well, I don't know how you could differentiate between them.
It's quite difficult.
Yeah.
Time frame? what she's taking there? When would you expect her to get withdrawal without asking her?
Well, withdrawal. What you mean, like how long if someone's been on opiate for 1 week?
So
2
she's on
weeks,
OxyContin, which is a sustained release short-acting medication. She's on Endone, which is an intermediate release.
It takes about 3 weeks, is my understanding, for someone who's on an opioid on a chronic basis to develop this type of diagnosis of substance use. Beyond 3 weeks, you're sort of addicted. So you talk about the dose during the day.
No, I'm talking about what
the half-life.
The withdrawal. So she stops today. When could you predict that she's going to present in this?
So you're talking about
4 to 6 hours.
couple of, I'd be more general. I'd say a couple of half-lives of whatever drug she's taken. So by the time you get to 3 or 4 half-lives, you should be seeing that.
Is that today, tomorrow, next day, next week?
Yeah, 24 to 48 hours.
Yeah, within a day or
that's
two.
what she's taken.
Yeah, remember, OxyContin is still a short-acting medication in a sustained release formula, so it will have a shorter acting. It's not a prolonged release. It's not a prolonged half-life.
One of the interesting things about OxyContin, when it was first marketed by the drug company that was promoted in the early 2000s, they claimed that it was a BD dosage. It's actually a TDS dosage. So it wears off actually a bit faster than what the literature was.
Does that mean we should be prescribing it TDS?
Yeah, if you're using it for pain relief, if you're one of the people who prescribe it, yeah.
Yeah, which means reducing the overall dose. So
Correct.
the daily dose remains the same, but the if you're on 20 BD, you don't go 20 TDS.
Yeah.
You've got to drop it down.
Yeah, agree.
All right, we'll go to just the next slide, and we're just following on from that. So depends on how many, and we haven't got a full history to find out exactly with Mel. She's certainly not mild, so everyone who answered moderate or severe is correct, depending on how much you interpreted from here. But this is the way DSM-5 classifies the range of this disorder. And the moderate and severe categories are very similar to the ICD-10 and the old DSM-4 criteria, so of dependence. So basically, unless you're mild, you've got a drug dependence in the old term. And drug dependence here is not just physiological dependence, but it's a synonym for addiction, although we don't use the term addiction as often because of the stigma involved with it, just the terminology itself. We'll go to the next bit here, and we'll actually move on to the next one. We've covered that already. So, a little bit of a break from the things. We've got a chance to just clarify any questions from the chat room. And so I'll let people type away if they've got anything they'd like to find out. And there was a question I ignored earlier I'm going to get to now. Oh no, we'll get to that later on because we're going to cover that later on. Oh, here's one. If you're going to refer to a hospital, there will be a waiting list, potentially, for a pain clinic, for example. So if the patient's coming back asking for more medication while they're on this never-ending waiting list for a pain clinic appointment or a psychiatry appointment or whatever it may be in the public system, which is often very difficult, especially in regional areas.
Well, do you want to get stuck into the treatment now, or
no, I think
it a bit later?
Just how would you approach someone who you've got a plan, but the plan isn't able to be actioned yet? Negotiating. So I suppose it's a negotiation with the patient.
We have to work out what's feasible within the framework of the person's work, their ability to get transport, how severely it's affecting their relationships. All those other psychosocial things will determine how urgent this particular case is. I mean, if you feel that the patient is so ill, critically ill, well, then they need to go to the emergency room. And then the emergency room can then take the steps to work through the psych liaison unit, or whether to get an immediate addiction medicine consultation or not. But in this particular patient, it's clearly an outpatient type of case that a GP should easily be able to start the ball rolling.
I'll just hold off on that a second. I've got a couple of other questions. We'll come back because I'm just thinking of the logical flow here. Someone said, Asif mentioned that the wait around his area is 2 to 3 years. So it can be quite unwieldy, really.
Hone up your skills on addiction medicine.
Would you ask her, does she think she's got a problem?
Yeah, absolutely.
As blunt as that, or do you soften it up a bit?
That's that call out.
Yeah.
Do you think you've got a problem with substances here? Does she say, and then she says no? Well, I do.
Yeah. Well, the other thing is, why do you think the pharmacist is considering?
The pharmacist does as well.
Yeah. Another way of asking these sort of questions, sometimes it can be very personal and sort of an affront to be, do you think anyone else around you thinks you've got a problem? And it just takes them to think about the effects that maybe others may have mentioned things and they may not have the insight, but they may disclose that even though they don't believe that. So a number of ways of doing that. What about long-term benzos? How about that long-term benzos lead to tolerance and increasing anxiety?
Absolutely.
Mm-hmm.
Right.
Yep, agree.
No one's disagreeing with that
No.
one?
Right on the mark.
And dementia.
Okay. All right. Keep rolling the questions in. We'll cover them as we go. But we've got one more poll, I think, to go through. I think it might be the last poll. Bit wordy, this one. So regarding Mel's treatment, would you, as her GP, recommend one of 5? We've got to choose one of 5. So reducing the amount and frequency of drugs gradually via supported counselling and judicious prescribing. Would you? Have we got that poll open?
Yeah.
Yep. Okay, great. Would you advise abstaining from all the drugs? Basically via a detox program, a short-term withdrawal. Would you advise continuing with the drugs but under strict medical supervision, involving a single pharmacy, a patient agreement, urine drug screens, no early refills, etc.? Would you advise that she finds someone else to seek help from? Or finally, would you advise she commences an opioid substitution program, which is basically methadone or buprenorphine naloxone combination? So 5 different options there. You just see where everyone's sort of overall comfortable in treating this. So we'll wait for some. We've just got over half responding so far. Thank you for responding so far. It's interesting seeing the numbers come through. All right, 2/3, a little bit more time just for a few stragglers to make up their mind. All right, we might close it there, thank you. So just going through that, 2/3 of you have chosen number 1. So asking her to basically recommending she does a slow gradual reduction with a lot of supportive counselling and very careful prescribing around that. A few suggested abstaining through a withdrawal program. No one's picked the middle one, which is basically continuing with the use but much more strictly supervised. Then we had 1 in 10 or 1 in 9 suggested finding someone else to seek help from, and then we had about 1 in 6, 1 in 5 suggested recommending an opioid substitution program for her.
Sorry?
He expects me to do maths at this hour of the night.
No. So the majority picked number 1. And what I might get the panel to do is just briefly, not going through a whole thing, but briefly, what are your thoughts about the different options? Just some ideas from your experience.
I think that this case is a case of 1 and 5 combined. I think number 5, opioid substitution using Suboxone, is the preferred method for this particular patient. And I think also that reducing the benzodiazepines by substituting the short-acting benzodiazepines for long-acting benzodiazepines, strict pickups from the chemist dispensed on a daily basis. Patients should take the benzodiazepine in divided doses, not as a PRN type of situation, so you can stabilise her serum levels out. And then the standard is to reduce by 10% every 2 weeks. So doing the frequent review. I believe that in this particular person, methadone's not such an appropriate thing because she's still got the ability to go out and get oxycodone and run the risk of overdosing.
We'll get more detail a bit later.
So I really want to know how, I'll flip this back to patient-centred again and start seeing what Mel's goals would actually be. Because I think that's going to direct a lot of what we do here. The other point is that we're never really alone. I mean, I know it seems, but particularly in Victoria, I know not everyone's from Victoria, Conrad's from Queensland, is that we do have some services here. You can ring DACUS, you can ring the local drug and alcohol service. There's often GPs in your region that may be prescribers who may have some more insights than you've got. So there is always the ability to get help if you're feeling a little bit overwhelmed and underskilled.
Can I add, Cameron? I see choice 1 and 3 as being the same for this patient. I think if we decided that we were going to try and wean the patient or reduce the amount. The fact of life is this patient isn't going to do that unless they're in a very supervised environment. So the ability to choose those is very difficult. And I just find it amazing that nobody picked number 3 and 2/3 of people picked number 1. Now, the other thing that I would point out is that within this country, this patient will be classified as somebody who is substance dependent. And it's actually illegal to prescribe S8 drugs for this patient without a permit. So 2/3 of people who have decided that that's a reasonable way to go actually need to think about their medical license, because they may find that they may be harming themselves more than they're harming the patient. So it is really important that you actually think about the implications of your actions here. So yes, we do need to take some aspects of number 1 into our treatment, which is the wean and define, but we need to incorporate it in a legal, structured manner, and that's what these opiate substitution programs are about, I believe, for a patient such as this.
Okay, Cameron, anything to add to that options? It's all wave our hands, the automatic centres. All right, so this next slide just goes through a number of things to consider when you're considering what sort of treatment. So recommendations. Obviously, if Mel's not interested in anything and just wants to leave your room as soon as possible after just just to say to the pharmacist, I've been assessed and not much else, then there's limited options. But to some extent, some recommendations, even for the pre-contemplator, is important. So at least they know where you stand, so they can come back, having thought about it, maybe another crisis or something, come back and say, look, you've talked to me about this option, let's go from there. So what I thought we might do is just go through each of those options in a little bit more detail. We've sort of alluded to a few of them already. So this is number 1. What are some advantages of this? Why would this be a good option? This is what the majority have chosen.
They will see you frequently, which gives you the opportunity to continually talk to them. But I do actually agree with Michael in this, in that they're going to run or they're not going to reduce their drugs, because it is incredibly hard to do unless you've got a very strong therapeutic relationship with Mel. So the advantages are that they are seeing you frequently. They can still get drugs from everywhere. So over to you, Michael.
Over to me. I think
we'll go next slide. We'll do one at a time.
All right.
Other than flop a dead horse.
All right. This is an excellent way of disengaging the patient and making sure that they never ever come back to see you again.
Why?
Because we're asking them to do the impossible, and the fact of life is, if they were coming to see you and they could have done it themselves, they wouldn't be seeing you. So a short-term detox is going to need a lot of extra support. It is an option that I actually give my patients. Very few of them select, but if they wish to do that way, there is an in-home detox with appropriate supervision, or there's a hospital-based or a detox-based option that Mel should be given. Having said that, I'm cynical that she would succeed, but as the earlier person asked, how do you treat the patient? How are you non-judgmental? Well, guess what? It's the patient's choice, and I'm standing back and I'm giving Mel the choices.
Sorry.
I was just about to say, home detox is a hardcore thing to do on your own. I wouldn't do it on my own. I'd be doing it with a team around me if I even got anywhere near that as a choice.
Well, I'd go even further out on a limb and say I'm not sanguine at all about home detox. I would say to the patient, look, I just don't get involved in doing this, because the failure rate is just so high. It's a recipe for disaster. Only inpatient residential, if you're considering that approach.
Can I point out that a detox by itself, especially for opioid dependence, has a higher mortality rate than those that just continue using the drugs. And the reason is, over the detox week or whatever it may be, their tolerance drops, relapse is really high. So as soon as they relapse, they often relapse to the same dose they were using, lower tolerance, and they can actually be having an overdose with the same dose accordingly. So it's not a good idea Any real role for a detox is where it backs to back in some sort of residential rehab, where it's a necessary process for real treatment. It's not a treatment in itself.
And if you live somewhere where you can't offer the residential detox, or it's going to take till the next century to do
don't
that,
do it.
don't get involved in it.
Next slide. Let's see what the next one was. All right, so continuing, but offering a real strictly supervised, good, tight program.
The scripts of death. High doses of opioids greater than 100 milligrams equivalent of morphine plus all that truckload of benzos is a script of death. You are running a really big chance of explaining yourself in front of a coroner at some point if you're going to do that sort of program a lot, as well as all of Michael's concerns about permits, notifications, and breaches of just about every state Drug and Poison Act around the country, which says that you should not be prescribing to maintain an addiction except under very specific circumstances.
I think it's a fool's paradise really to think that you can successfully manage a problem like this, because apart from all the medico-legal issues that Cameron and Michael pointed out, you're going to run and killing them as well. That's a good point. But the other thing is, invariably in this type of situation, you're going to run into dosage escalations, missed my dose, forgot my dose, early pickup, someone stole it, hoarding, having these drugs at home where children and other vulnerable people might be able to get access to it. It's really a strategy for failure, and you're just kidding yourself that it can be managed like that, because apart from the fact that you're prescribing the opiate, again, as Cameron said before, they can still get it from anywhere.
And I'd add to all of that, not just the permit to prescribe, but if she's attended and you haven't prescribed, you're also duty bound to report her to drugs of dependency as a notification.
That's in Victoria. Other states may differ with that, but in Victoria, certainly.
Those forms are available on the Drugs and Poisons website, easy Google find.
Yeah.
But you can just write a letter if you wish. You point out the patient's name and date of birth, and Drugs and Poisons will accept that.
So if you do decide to do this strategy, should really change it into strategy number one, only for the benzo, which is weaning the benzo off, but under the strict medical supervision, etc. But I'll only do that for the benzo.
Sorry.
And the benzo negotiated contract should be as a one-way wean in the ideal world.
Absolutely. Yeah.
There's a comment here about applying for S8 permits that often take many months before they actually come back. It depends on the jurisdiction and the workforce available at the time. So in Victoria here, it varies from even a few days, sometimes to come back to many months, and it really varies. Victoria's law is in applying, provided they're not drug dependent. If they're drug dependent, you must have a permit available to you before you can prescribe. But for anyone else, within the 8-week period after you've exhausted that time, you apply for a more normal permit rather than a drug dependent permit. In the act of applying for it, you've fulfilled your obligation by the law. So if it takes 3 months to come back, it takes 3 months to come back. More than likely, they're being triaged, and the ones that will be knocked back are knocked back much sooner than 3 months down the track. So it's usually no news is good news. If you're concerned, give the Drugs and Poisons unit, whichever state you're in, give them a call, because they're actually quite good on the phone in guiding you through whether there's likely to be a knockback or not. If you've got concerns, they can help you guide whether there's been other notifications, for example, for your patient itself. So the time frame shouldn't be a big issue, but the main thing here is someone like Mel, who is drug dependent or has moderate to severe substance use disorder, you have to have a permit before you can prescribe any further opioids once you've got that history. That's a really important point there. Next slide. Seeking someone else to find help for. So I'm assuming, I'm making an assumption here, but I'm assuming those that have ticked this as their preferred recommendation are feeling quite overwhelmed and either under-resourced or under-skilled in dealing with this and navigating the treatment pathway. I'll go through who to seek help from in a second. Some pros and cons of this approach.
Look, I think that if people aren't comfortable in treating Mel, I think it's sensible and good practice that they pick up the phone and ask or refer on. I think the important thing from the duty of care is to deliver that to Mel in a timely manner so that she's not left hanging out for 6 weeks to find an addiction medicine consultant to see I think it's something that needs to be dealt with fairly urgently.
Yep.
And one of the unique things about addiction medicine consultants is that they often, invariably see people on short notice because of the nature of the illness. And you can and do find that, including the telephone support services that Paul
I'll
mentioned.
go through those services in a second. I suppose, for me personally, I found this area of medicine very rewarding. It is very challenging, but with that comes its reward, and it's actually informed my broader general practice much more effectively. I actually assess my other chronic disease, my asthmatics, my diabetics, those that are struggling with other chronic diseases much more effectively because of the skills I've learned from this. So I think all of us at some stage are de-skilled and not skilled in this area because it's taught very poorly in all medical schools and most training programs. So a lot of us coming into this fairly naively and can feel quite overwhelming, especially with some of the context patients coming with. But getting some skills in this area can be a very useful part. It can be very enriching, I suppose. I'm appreciative of converted here because these guys wouldn't be here if they didn't enjoy this job and wouldn't be doing it. And we're doing this webinar because we want to share this enthusiasm of the topic. But I think it's an important skill to develop over time. We'll go to the next slide because it'll go through a couple of things. So in Victoria, we have Direct Line, which is an idea of where you can also treatment services. And patients can call that, and it also provides some patient counselling. Other states have got different phone numbers, and you have to look up each state. This is, again, a Victorian faculty webinar, so I apologise to those from interstate, but there are services there. The next thing here, in Victoria, since last year, we've got new referral pathways, so we can no longer refer directly to a service. We refer to our regional provider, and they do an intake and assessment and then pass on the information to a service provider.
And this is about to change very quickly because there's a huge review done on this. With most of it's
so this is how it stands at the moment, but we're actually, as a committee, we've been working very hard to try and make this easier for GPs because, to be honest, it's a bit of I would say disaster,
hit and miss.
A mini disaster, let's put it that way.
Hit and miss.
All right, next one. Okay, so this is the last of our options. So recommending opioid substitution therapy, which involves methadone or Suboxone, which is a buprenorphine naloxone preparation.
Yeah.
Rather than go through on this slide, I actually just broadly, before we talk about, excuse me, Cameron, before we talk about these drugs individually, just broadly, what's the principle? Why is replacing one opioid with another a good idea? Aren't they already addictive?
They're long-acting. They're under your control. So you're prescribing a set amount regularly. They're coming back to you for the prescription for regular contact and regular review. What else? Supervised.
The whole principle of this is harm reduction.
Yeah.
Takes them away from
the evidence has demonstrated an increased survival, a decreased cost to the community,
decreased death rates, survival after release from prison if they're on methadone when they get out.
Yeah.
So the
all those
evidence
things
really stacks up in favour, and it's good medicine. These people get to work, back to work, regain control of their lives. Anecdotally, the literature, everything supports.
Yes,
takes
actually,
them away from the chaos.
I'll try and link this. There's a document that's only come out just recently, Medication-Assisted Treatment for Opioid Dependence, Review of the Evidence by the Australian National Council of Drugs. Methadone particularly, because it's been around for longer, for both these substances, are some of the most evidence-based treatments we have in all of medicine. We'd like to thank the Americans for that because of their abstinence policies over the years. To get these drugs over the line took a lot of evidence to convince the politicians and the cultural shift. And so they're actually very, very well evidence-based. And to be honest, in prescribing them, they're simpler than warfarin, simpler than prednisolone. There's less things to think about. It's the context of the patient that's complicated. The drugs themselves aren't that complicated.
Yeah, I don't know if I totally agree with you. First of all, just going back to the evidence, just go into the Cochrane library and look up methadone or Suboxone or buprenorphine in terms of harm reduction and risk. It's all there, plain and simple. I've got a different view with you regarding prescribing it. I think really if you don't do much of this type of medicine you're probably better off seeking out one of your GP colleagues who does quite a bit of it, or as Michael Aufgang said before, seeking out a specialist. This area now is becoming fraught with difficulty because of the amount of polysubstance use and the amount of comorbid mental illness that's involved. And I think what we're seeing is this rapid rise in deaths and morbidity in relation to prescription opioids and prescription benzodiazepines. If you're not confident in dealing with this type of patients, it's probably really a better idea to refer on and not get involved in doing it. There's no good to take a piecemeal approach. Well, I'm going to give it a try on someone. You need to learn and you need to feel comfortable. You need to be mentored.
Thanks, Rob.
Sorry.
I agree. It certainly can be complicated. Again, the drugs themselves are quite straightforward, but it can be quite complicated. And certainly, if you're not comfortable, don't take this on just without any further training or mentoring as part of it itself. Let's go through. We've done some chat room stuff, and I'm going to borrow someone else's thing. I'm going to put a link up to that review. So that's going now on an irrelevant comment to the actual topic, but I've posted it up there. We'll go through a couple of slides. Next one as well. So, how does methadone work, Cameron?
How does methadone work? So methadone is a high reward opiate. It has a long half-life. So you are, in a way, making somebody addicted to an opiate that you're prescribing, so that in the long term they get some stability in their lives, and over the very long term they start to reduce and move towards recovery. Is that a brief enough answer? Usually I'm a lot more verbose.
Okay. How does it stop someone using drugs? Opioids, not benzos, but the opioids themselves.
So you're saturating, I think it's a mu alpha receptor.
Mu opioid receptors.
And you, by doing that with a very long acting drug, very long half-life, 24 to 36 hours, it is occupying the receptor so that other opioids are going to be substantially less effective if they actually penetrate. So it takes away.
It doesn't actually have a very sticky affinity. It's usually actually the tolerance. So the above 60 milligrams of morphine a day, you develop enough tolerance that other opioids don't have as much effect. That's probably the biggest factor.
So there is satisfaction. Is what I was driving at.
You lose the thrill of your street heroin and OxyContin.
It's got a low gradient. It's the rapidity of the onset. Methadone's got a very slow onset, and as Cameron was saying, it's got a very long half-life. So therefore, you don't go through the withdrawals that you would of a shorter-acting opioid like morphine or heroin. So the patient has stability. They're not going into withdrawals. As you get up to 80 milligrams of methadone, you get towards what's known as a blocking dose, where theoretically using other opioids on top of it will not have any adverse effects. However, it does have a great adverse effect if you're using opioids on top of 80 milligrams of methadone. Risk of death is high. Respiratory depression is the problem.
So the next slide, looking at buprenorphine naloxone, which in Australia comes in a brand called Suboxone. It comes in two strengths. It's a sublingual film, so it gets absorbed sublingually over a few minutes, basically. Sort of that film dissolves. A lovely lime flavour, I'm told. You want to know how this works?
So it's a partial antagonist of the mu opioid receptor, but it also works on the delta and the kappa receptors, the significance of which is not really known, although it's thought to give it its protective effect against respiratory depression. So with buprenorphine, which is the active ingredient in this combined drug when it's taken sublingually, the naloxone doesn't get absorbed into the bloodstream, most people would say, when it's given sublingually. So it literally has no effect. The buprenorphine itself, which is the active ingredient, it also saturates the opioid receptors. The beautiful thing about buprenorphine is in people who are addicted to opioids, they cannot get respiratory depression from it. And not only that, and this is a significant advantage over methadone, is that it's a blocker. It's very, very highly competitive to the mu receptor. So if you use opioids on top of buprenorphine, they will essentially be ineffective, which of course may lead to problems in analgesia in hospital type situations where people require it for surgery or for motor vehicle accidents. But the beauty of this is there's no ceiling. The ceiling dose is generally about 32 milligrams as well. And unlike methadone, which you can overdose on, you cannot overdose on buprenorphine.
One of the slight drawbacks is that because it's not as high reward an opiate as methadone, is that when you look at the life cycle of somebody who has substance problems, they will jump on and off a Suboxone program more than they will jump off a methadone program, and that's from the large data sets from Edinburgh in the UK. What that means is not all that clear, although I guess when you're on one of these opiate replacement therapies, you are more likely to be alive in a house, in a job, out of prison, with your kids, with your partner. And when you're off these substances, you're more likely to have all the problems associated with your substance use.
Absolutely.
So in Victoria, we've got slightly different rules than a lot of the other states, and I'll just go through them. To prescribe methadone, you need to have done a full day's training, and that's pretty much universal across most of the country. And that training also covers Suboxone as a drug as well. But in Victoria, there's an exception for Suboxone where any GP can initiate a patient on Suboxone for opioid dependence, and only for opioid dependence, for up to 5 patients without having done any formal training. Now, it's highly advised to get some training, and I've just linked to a page on which talks about some training opportunities. Now, the calendar's a bit out of date there, so ignore the calendar part, but the contact details to find out when training's available. There's some online training as well as face-to-face training you can go to just to upskill to a point where you can do that, and that's quite short and sharp training rather than a whole day. So there's training available, and you can currently prescribe without training, but we'd strongly recommend, as Rob alluded to, having some training so you at least know your way forward from here. I've got a question here from Conrad. Doses below 2 milligrams not available in combination with naloxone. That's correct. Subutex is a buprenorphine only formulation. Every state may have different rules. In Victoria, you can only prescribe Subutex for pregnancy, documented allergy, or for those that are coming off the program eating less than 2 milligrams to actually wean off their final doses. So you wouldn't be using less than 2 milligrams anyway. It'd be certainly subtherapeutic from an opioid dependence maintenance program from that point of view. We might move on. We want to make sure we finish on time. So we've talked about a few resources, and we'll go through those individually. Every state has a version of DACUS. So I'm giving you the Victorian version here, and actually everywhere. The website's actually quite useful no matter where you're from, but the phone number is basically a Victoria-specific one. Every state's got an equivalent where you phone up usually a paging service, and a drug and alcohol specialist will get back to you with advice about your question. So a very timely and responsive type of program. And it's probably one of the few areas of medicine that have this sort of specialist on call available to us. If you're considering drugs and poisons poisons rules like permits, or looking for further training, there's a link there. And if you're looking for these and you can't actually click on the page, again, the handouts part of the panel will give you this slide that you can actually download it and utilise from that. There's further information there. And I want to just point out the overdose naloxone info. In Australia, we're now following international, I suppose, programs looking at prescribing naloxone for patients who are at high risk, or you think they are, or their colleagues or families are at high risk of an overdose. So the most important risk factor there is a previous overdose or close near overdose. So someone who's ever had naloxone administered to them or an ambulance called for an opioid overdose, they're at high risk of happening that again, or also at high risk of witnessing one. And so we can prescribe naloxone as a harm minimisation approach while someone's calling an ambulance to save someone's life or buy some time.
Naloxone comes in 5 little mini jets, which are available on the PBS.
Yep. So this is all available on the PBS, and so someone with a healthcare card, a $6 investment in basically, it's a bit like an EpiPen, but basically for opioid overdose, and you don't need an allergist to authorise it. We can do this from scratch. So just be mindful, if someone with a history of overdose or you're very concerned, it's a nice way of opening up a discussion about the dangers of injecting or the use, not necessarily injecting, and also a possible solution for them. Now, this is being brought to you by the Drug and Alcohol Committee of the college, and we've also, Michael's chair of the National Addiction Network of the National Faculty of Special Interest. Both of these organisations are formed to support GPs. Some of us are a bit more expert. We've got members who are less expert. They're very collegial committees. So if you're in Victoria and you want some more information, there's an email address there to flick to, and I'm chair of that committee, and I can certainly guide you in the right direction, and we welcome visitors. And the Addiction Network has got hundreds of GPs now on the books from around the country. So if you're interested in this webinar, and you are because you've stuck around for this long, we strongly encourage you to at least be on the mailing list for the Addiction Network, the national one, because you'll be up to date with things as they come about, and just keep in the loop. And it's certainly no commitment to involve, but if you want to get more involved, you certainly can.
Costs you nothing, sign up.
Where are the membership forms?
Online. You can just send an email to
Send that email
that address, and then Pam will send you back some stuff from the college. It's pretty easy.
Now, again, sorry for those interstate people, Victoria specific. Victoria's been divided up into 5 regions that are there, and they're fairly new, so they're sort of evolving, but basically to support pharmacotherapy for opioid dependent patients. So we've got regionalised support networks, and each of these networks have a coordinator or 2, depending on the size and who's involved. And again, we'll have those links available on the handouts page, so you can email those directly if you're looking to get some support. It doesn't mean you have to be involved, but if you've got a patient you're not sure about and you'd like to know a bit more about who around you is involved, for example, if you're working near me, Jackie, who's my person, may actually, I'm in area 2 where I work, Jackie may actually flick me an email to contact you and give you some mentoring support. So it's a nice way of peer-to-peer support as well as some training support things. So there's another page to go, just looking at the metro options. So again, if you're in Victoria, you should be able to work out where you fit. So Metro Area 4 covers a wide expanse, east and southeast in Melbourne there. So they're newer things, and they're developing, and they're certainly aimed to integrate with general practice as much as possible. So we've got a bit of time left to answer some questions before we can finish off, and thank you for the comments. And we've got a lovely comment that says, I'll post it there. Thank you, best webinar ever attended. Well, that's very nice to hear. I hope you attend more webinars, because I'm sure there's some better ones out there as well, but pleased to hear that feedback. So our take-home message is really here, very simple, as you can see. There's a lot of substance use issues that are hidden from us, particularly with over-the-counter medications, and Mel started with this, but then developed into a doctor shopping picture, so prescription as well. But over-the-counter opioids are a significant problem that we're just not seeing, often because we're not assessing and looking for it, and often because patients aren't seeing us, they're seeing the pharmacist instead. So occasionally we'll get a pharmacist like Mel's pharmacist will flick them towards us. We need to be able to respond. And so I think every GP should be able to do a proper assessment and offer help. Now, whether it's you're doing the help or whether it's offering help through another treatment provider, I think it's a core skill for a GP, and it's certainly part of the college curriculum as what we should be doing as a college fellow.
Adding to that second point there, it's crucial that you do a management plan. Plan what you're going to do. Don't just do something ad hoc, prescribe this, prescribe that. Write down a plan, give it to the patient. It doesn't have to be your formal management plan. You can do one up later on. But write down on a piece of paper what you're going to do, what your expected goals are, and what you're going to do when you come back for review. It gives the people framework, which is so desperately needed.
One of the questions that comes up is, this takes a lot of time and I'm too busy with this and it doesn't pay very well because it's just a consult. We've got to make the most of those plans. Opioid dependence, benzo dependence, they're both chronic diseases in general. They'll last more than 6 months, and they're also mental health disorders, being in DSM-5. So they qualify for those EPC type of programs that you can utilise to offset some of the costs of extra time you need to spend with these patients. So a few more take-home messages. Opioid substitution treatment is highly evidence-based and actually is the best treatment. It is first-line treatment for opioid addiction. So think of that all the time, and if you're not comfortable doing that yourself or being skilled up, make sure you've developed a network where you can source that. And please develop your own networks. It's as I said, a core skill that's under-trained, and it's an opportunity. And I'm glad we've been able to share this webinar with you to actually help with that training. I want to thank Rob, Michael and Cam for their expert opinions and lively chatter and a bit of banter as well. Behind the scenes, you can't see on the screen, but Nicole has been fantastic moving the slides, doing the polls. It's her first webinar with us. I think it's her first week with us. So a little silent applause from the crowd and a loud one from us. For her assistance. It's been fantastic. And particularly I want to thank you, our audience, for being so interactive and sticking with us for 2 hours. It's been fantastic. We'll see you next time, and bye for now. And we'll close the screen.